awardees. These are the abstract award winners, so those who have submitted abstracts and been awarded a grant from the UK Myeloma Society over the past year. So we're going to start the next 2 talks before coffee with the EHA abstract award winners from this year, and then after coffee with the IMS abstract award winners. And so I'm delighted to invite Sinna Beer, who is a haematologist currently working at the Institute of Cancer Research in Royal Marsden Hospital in London, to present her abstract, Challenging the Concept of Functional High-Risk Myeloma Through Advanced Transcriptional and Genetic Profiling. I should let you say it.
Bit difficult title. Hi, everyone. Good morning. I'm very happy to be here and have the opportunity to present my abstract that I submitted at the EHA conference this year. I won't read the title again. It's about challenging the concept of high-risk, functional high-risk myeloma. And just to give you some context, functional high-risk myeloma, and I'm aware that you are probably all know this, is reported in up to 50% of patients with early relapse. However, we always should consider that these figures often derive from heterogeneously treated cohorts with incomplete molecular profiling. And on top of this, current high-risk classifiers or risk classifiers still omit validated gene expression profiling. So the aim of our analysis was to identify the true frequency of functional high-risk myeloma and the prognostic value of gene expression profiling in a uniformly treated myeloma 11 trial subset of patients. We included in total 135 patients of the myeloma 11 trial. They were homogeneously treated in terms of all receiving an autologous stem cell transplantation, and all were randomized to lenalidomide maintenance. They had complete information on tumor genetics as per the updated IMS/IMWG guidelines from this year, and they also had complete information on gene expression profiles as per Sky92 assay. And as you can see here, of the 135 patients, 25 relapsed early. We defined this as a relapse within the first 18 months after autologous stem cell transplant. And we had particularly 2 main findings that I want to highlight in this short talk. So the first finding is that when you apply a comprehensive profiling, true functional high-risk myeloma gets very, very uncommon. So because when you look at the small figure down there, 15 of the 25 patients were IMS/IMWG high risk. 6 of them were only gene expression high-risk patients, so you would have missed them with IMS/IMWG high-risk stratification. 2 of the patients had at baseline diagnostics single high-risk cytogenetic aberrations, and that remaining 2 of them were true functional high-risk myeloma in our analysis. Interestingly, both 11-14 translocated. So this is the first finding. And the second finding, when you look at progression-free survival of the risk groups and compare them, you would appreciate that the standard risk patients, they do fairly well after a long follow-up of 144 months. But the gene expression high-risk patients and the IMS/IMWG high-risk patients, they do equally bad. So high-risk gene expression alone conferred to high early relapse rates and poor survival outcomes. And with that, I can already conclude that our findings highlight the need for broader access to advanced diagnostic tools in both research and clinical practice. And such tools would help us to identify patients at risk for early relapse and poor outcomes, but also to more accurately define true standard risk cases so that we can better stratify treatments in the future, hopefully. And with all that, I just want to thank you for your attention. Thank you to the whole Myeloma 11 team and the opportunity to present this subset data. And a special thanks to Martin Kaiser and his whole team. Thanks.
Fantastic. Any questions for Zina? Sorry, far over there. No.
Thank you. Great presentation. So the two patients who didn't meet the criteria for conventional gene expression high risk were 11, 14. Do you have any insights as to why that may be the case?
So why these two patients?
Why specifically about the 11, 14? So we know that 11, 14 in general
is a bit special.
Abnormality, but there's clearly a mixed picture for 11, 14 myeloma with association with plasma cell leukemia, for example.
So we have unfortunately no data on circulating plasma cells to identify, to classify them as plasma cell leukemias at the beginning. So this is something we miss. And also on top, we have looked in these patients, but there's not. We also do not have any imaging data. So maybe they had some extramedullary disease, which could explain the early relapse. So this is the two things that we are missing: CTPCs and EMD diagnostics. So maybe this can explain it.
No other additional molecular data of other abnormalities?
No other, like in the mutational profile, so there was an extensive workup on them, but there's no other, like, little thing that we could identify. Sorry. Yeah.
So you looked at the molecular data for the patients that relapsed. Did you look at the ones who didn't relapse, and how common were the mutations in the unrelapsed group?
You mean the gene expression profiles?
Yeah.
So they were lower. I just have a quick look if I have some data. I don't think that I have the data here. But so we definitely looked at the other group and the gene expression profile high risk patients in the group which had late relapse or no relapse. And it was definitely lower because gene expression profiling is actually quite specific. So I cannot tell you the exact numbers, but I think we can work it out from the table here, if you give me a minute. What I can definitely say that, yeah, they only 19 patients of the other group had gene expression profile high risk. But we definitely have them also in the other group. This is something. But it can stratify more specifically when you use both of them.
Can I ask one more? Over here.
Oh, yeah.
Hi. I was wondering if your gene expression profile captured the PR cells, cells with this proliferative index, and if yes, do you see any correlation between PR signature and progression?
No, I haven't looked at the PR index. Maybe Charlotte, you can?
There's a very high correlation between Sky92 gene expression and PR. So there's a lot of it is captured within the same. Like, last question for John. Then we have to, sorry, whoever was first, and Jan.
Yeah, thanks. I was just wondering, what happened to those two patients of the 14? Did they go on to get subsequent therapy and do well, or did they do badly with everything? Do you know?
Those two patients finally, I mean, they obviously relapsed early and then get some other treatment and relapsed again, and they unfortunately both are dead at the moment. But I mean, it's a long time ago, like,
yeah.
So, sorry.
Thank you. We'll move to the next speaker. Our next EHA Abstract Award winner is Dr. Dominic Fowler-Shorten and from University of East Anglia. He's going to talk to us about age-associated macrophage polarization to an M2 phenotype drives myeloma proliferation in an aged marrow by loss of tumor-associated phagocytosis.
Thank you for that invitation. So I will just clarify, I'm currently a PhD student, so not a doctor, but yeah, so I'll swiftly move on to here. So myeloma interacts with multiple immune populations within the bone marrow, and in particular, I'm interested in the role of macrophages. So macrophages polarize across a spectrum of phenotypes, and it's reported that M2-like macrophages resemble a pro-tumoral phenotype in the bone marrow niche of myeloma. So here, our work aimed to characterize age-associated changes in macrophage phenotype and function during myeloma development. So we have used the 5TGM1 mouse model of myeloma. The Calraj strain, which is a substrain of the traditional C57 black 6 strain, was found to develop MGUS with increasing age, and notably after 2 years, around 1% developed myeloma. When you harvest and transplant these cells into young Calraj mice, they develop myeloma within 30 days. We and others, however, have shown that these cells don't engraft in young C57 black 6 mice, and it led us to hypothesize that aging might create a permissive bone marrow environment for myeloma to develop and give a much-needed aging mouse model of myeloma. So to assess this, we injected young, middle-aged and aged female black 6 mice, and after 30 days harvested the spleen and bone marrow. And interestingly here, we found that only the aged mice engrafted, and this was consistent with an elevated paraprotein in the aged versus young. We also, interestingly, did see elevation of paraprotein in the middle-aged mice, and we think this might indicate an MGUS phenotype, but more work is needed to clarify that. To then look at the underlying mechanism permitting engraftment in this aged bone marrow, we assessed M1 and M2 phenotypes by flow and found an elevated M2 to M1 ratio in the aged bone marrow. We also assessed the ability of macrophages to engulf E. coli bioparticles, and here found an impairment in their ability to phagocytose, that is, the aged macrophages. We then wanted to develop an in vitro system to characterize the M2 relationship with 5TGM1 myeloma. And here we found that the tumor-supportive M2 phenotype is recapitulated in this in vitro system. Having found this relationship, we obviously wanted to see if it translated clinically. So we identified some publicly available single-cell RNA-seq data sets of PBMCs from both healthy and myeloma patients. And what we found was a clear upregulation of M2-associated genes, and also, interestingly, upregulation of NAMPT in the monocyte macrophage cluster of myeloma patients. And this was consistent across multiple separate single-cell data sets. So NAMPT, I'll say, NAMPT is a metabolic enzyme that's important to replenish intracellular NAD stores, and this is important for glycolysis and oxidative phosphorylation, so very, very important to maintain metabolic activity. And as you can see here, there's a tight interplay between NAMPT activity and also CD38 activity. So this is the enzyme, or one of the enzymes, that consumes NAD. So we wanted to take these findings back into our aged black 6 model, and here we harvested bone marrow from both aged and young C57 black 6 mice and enriched for F480, which is a total macrophage population marker. And here we found notable upregulation of NAMPs in the aged macrophages, which we think suggests that aging may be driving NAMPT upregulation, and it might be a susceptibility for myeloma to develop. So last of all, we assessed the effect of inhibiting NAMPT or CD38 alone or in combination in our in vitro system. Treatment with NAMPT inhibitor FK866 alone had no effect on M2-induced killing of myeloma. However, what we did find was that 78C, a CD38 inhibitor, repolarized M2 macrophages to become M1-like, and that elicited a stronger anti-tumor response. And also, interestingly, combination of both further improved the response slightly. And this was also through repolarization to the M1 state. So in summary, we find increased M2 phenotype in the myeloma bone marrow microenvironment in our mouse models, and we also identify the NAD biosynthesis pathway as a novel metabolic target in M2 macrophages, where we find dual inhibition enhances anti-tumor responses. So last of all, I'd just like to thank all members of the Rushworth Lab in Norwich, and also a big thank you to the UK Myeloma Society and Pfizer for supporting my travel to EHA last year. Thank you.
Thank you very much, Kui.
Thank you, lovely data. I have two questions. When you inject tumor into young animals, if you give them long enough, would those tumor cells grow and recapitulate disease, but they're just sitting there quiescent at a younger age?
So we have followed it up as far as around 50 days in the young mice, and we still don't see anything detectable in the bone marrow or the spleen. But yeah, within this model, to keep it consistent, all the data here is within a 30-day model.
Thank you. Second question about CD38 inhibition. Is it known what anti-CD38 antibodies do to macrophage phenotype in recipients? I'm sure that it's known, but I don't know it.
As far as I don't know in the context of myeloma if anything is known, but I know it's been shown that so 78C repolarizes M2 macrophages towards a more anti-tumor phenotype. And it's not fully understood the mechanism how that works, other than that it restores intracellular NAD levels. Potentially it makes them more fit and active to kill.
Thank you.
Yeah.
May I pass this on?
Claire, yeah.
Thank you. That was really nice. I have two questions as well. So, first one, you showed the M1, M2 difference in your aged model. Do you see the same difference in the Calrai mice?
So yeah, in the young model, I haven't presented it here just for time reasons, but yeah, we do see the increased M2 phenotype in the young as well.
Okay, thank you. And then, is there a role for senescence in this somewhere?
Yeah, I think there definitely is. I have not explored that at this point, though. That would be interesting.
Thank you.
Brilliant, thank you. I think we've got to close. We're 10 minutes over. So we would like to have you all back in this auditorium at 10:55 to start with the IMS Abstract Award winners.